Good morning, my name is Fozia Ahmed. I'm a cardiology registrar, and today I'm going to talk you through the cardiac examination and what you'd need to know for the PACES exam. This is Christopher, who'll be our patient today, and we're going to get started. Good luck. Okay, so what you need to do firstly is set the scene. Start by having a look around the patient, looking for any oxygen cylinders, any aids that the patient might be using, such as a walking chair because of breathlessness, and comment on those. So I'll show you how I'll do it. Okay, taking a step back, having a look at the patient, checking to see that the patient's comfortable, breathing at a good rate and a good colour, making sure they're not cyanosed, they're not excessively pale, and they're not jaundiced. Next thing, you want to ensure that the patient is adequately exposed. And in Chris's case, he's got his top off. But if the patient has long trousers on, like this, then always ask them to roll them up. Chris, can I ask you just to roll your trousers up? The reason why we're doing this is that you want to make obvious any vein grafting scars that might differentiate a median sternotomy scar from being for just a valve replacement or from being from a cabbage and a valve replacement. Okay, so in this case, the patient doesn't have any vein grafting scars. Next, we're moving up to the patient's chest, examining for any scars and any chest wall deformities, and looking for any syndromic features such as Marfan's that you might expect the patient to be excessively tall or have a typical facies. So next we're going to examine the patient's hands. Can I take both of your hands, is that okay? So you're having a look at the hands, firstly turning the hands over, checking to feel that they're warm and well perfused and a good colour. Turning the hands back over, you can assess for any arachnodactyly that you might see with Marfan's syndrome. Look for any tendons xanthomata that you might expect on the back of the hands in familial hypercholesterolemia. And examine the fingers themselves, looking for any splinter hemorrhages that you might get with infective endocarditis, or Quincke's sign, which is pulsations in the nail bed that you see coming up here, that you might get with aortic regurgitation. So turning the patient's hands over, look for any evidence of any Janeway lesions or Osler's nodes. Osler's nodes are painful and purple, whilst Janeway lesions may be macular or nodular, both occur in infective endocarditis. Next, you want to assess the patient's radial pulse, and at this point I assess both together. You want him to assess the rate, the rhythm and the character. In this case, the patient's pulse is regularly regular, indicating that the patient is probably in sinus rhythm. It's important to assess both radial pulses at the same time to avoid wasting any time. It'll also give you an indicator that if the left radial pulse is weak, the patient may well have had a Blalock-Taussig shunt if they're young, which is something that they do in a Fontan repair. Okay. Next, I assess for radiofemoral delay, which will give you a clue as to whether or not the patient may have coarctation of the aorta. Okay. Having assessed the radial pulse for radiofemoral delay, we're next going to go on to assess for a collapsing pulse, which is something that you commonly get with aortic regurgitation. This is how I hold the patient's arm. So your fingers are across the radial pulse. I'm also holding onto the brachial, and I'm going to ask the patient if they have any pain in their shoulder. Do you have any pain?
No.
Raise the arm up and feel for a collapsing pulse. Typically get it with aortic regurgitation, but you can also get it in other hyperdynamic states, such as anemia and thyrotoxicosis. Okay, relax the arm down. At this point, I'd mentioned to the examiners that I would ordinarily measure the blood pressure, but I wouldn't wait for them to give you a response. I'd just simply move on with the examination. Shows that you've considered this part. Next, we're going to assess the JVP. Okay, so I step back from the patient. Chris, can you just turn your head slightly towards the opposite side? Make sure that the patient's head's relaxed and turned slightly away from you. And you're looking at the internal jugular vein, which usually runs here. Ordinarily, it should be just visible above the level of the clavicle. If it's elevated, then you will see it as being elevated. If you're not sure whether or not what you're looking at is at the JVP, then you can perform a few manoeuvres. Firstly, the hepatojugular reflex. I'm just going to press on your belly. Okay, and you may see the JVP rise. If you're not sure if what you're looking at is the carotid pulsation or the JVP, palpate it. It should not be pulsatile if it's the venous pressure, and it can be obliterated easily from above. So so that when you release your finger, you should see it filling. I'll show that it can be obliterated as well. Causes of a raised JVP. You can have a raised JVP if someone has pulmonary hypertension, any cause of elevated right heart pressure. But you're also looking for CV waves that you might get with tricuspid regurgitation. In this instance, you'd see them shooting up the neck. We're moving on to assess the carotid pulsation next. So use 2 fingers and palpate for the carotid pulse. You're wanting to comment on the character of the pulse, whether or not it's slow rising, as you would get with aortic stenosis, or whether or not it's bounding, which we may get with aortic regurgitation. We're moving on to examine the face, starting by looking at the patient's eyes, looking for any xanthelasma around the eyes suggestive of familial hypercholesterolemia. Look up for me and look down for me. We're also looking for the appearance of any malar facies, which is typical of mitral stenosis. What you would find is a pink discoloration of the cheeks. We're moving on to examine the mouth. Look at the patient's dentition. And if you can lift your tongue up to the roof of the mouth, we're looking for any cyanosis. Examining the precordium, it's important to inspect for any scars and any chest wall deformities. As you can see here, the patient doesn't have any chest wall deformities or any scars. You're looking for a stenotomy scar that might suggest a previous CABG or valve replacement, and also for any scars at the sides. If you can sit forward for me, and across the back, suggesting either a previous coarctation repair, a Blalock-Taussig shunt, or just general indications of previous cardiothoracic surgery. If the patient has a tracheostomy scar or other scars that might have suggested a prolonged ITU admission, then comment on these also. We're moving on to palpate the precordium. Start by palpating in the aortic area, in the pulmonary area, and at the bottom in the mitral and tricuspid areas for any thrills that you might get. We're also going to examine for where the apex is. Ordinarily it should be in the 5th intercostal space in the midclavicular line. Once you find the apex, make it clear to the examiners that you know how to describe where it is. So if you remember, 2nd, 3rd, 4th, 5th intercostal space. And we're just lateral to the midclavicular line here. So when you've found where the apex beaten, it's important for you to think as to whether or not the apex is thrusting as you would expect with mitral regurgitation or aortic regurgitation, whether it's displaced as in congestive cardiac failure or LV impairment, whether it's heaving as with aortic stenosis or hypertension, or whether there's a double apical impulse that you would expect with HOCM. We're now going to use our stethoscopes to auscultate. We're next going to auscultate in all 4 areas. Use the diaphragm of your stethoscope for this part. It's important to have a hand on the carotid pulse at this point in time, and you can feel the carotid pulse quite easily, just there. Some people prefer to feel the subclavian here, and it can look a little more professional, but the examiners may not know what you're doing. Okay. So we're auscultating in the aortic area, moving on to the pulmonary area, the left sternal edge, and at the apex. This is really just as a guide so that you know what murmurs you may be hearing and where. Next, you're going to auscultate in the specific areas. So I like to start with the mitral area and auscultating at the apex. What I ask the patient to do is to get into the appropriate position. So you want to ask the patient to lie on their left side with their left arm above their head. Just making it easy for them. Just raise that arm. That's great. Start by auscultating in the mitral area. Breathe in and out and hold it. Then move to the axilla. And listen in both these positions with, if you have a bell, the bell of your stethoscope. Okay. We were listening in the mitral area just then. The reason why you ask the patient to lie in the left lateral position is you're demonstrating to the examiner that you know how to accentuate murmurs. By asking the patient to breathe in and breathe out and hold it, you accentuate left-sided murmurs, which makes the murmur of mitral stenosis and mitral regurgitation appear louder. You're also examining them in the appropriate position. When we move on to examine the aortic valve, what we next need to do is ask the patient to sit forward. So relax back. Okay, so I'm going to start with the patient lying back like this, and then I'm going to sit him forward. You can sit forward for me. Feel for the carotid pulse, and then auscultate. Breathe in, breathe out, and hold it. Breathe normally. And again, breathe in, breathe out, and hold it. That's fine. If you have a bell on your stethoscope, then you should use this when examining specifically in the mitral area for mitral stenosis, but also when you're listening in the other areas too. By asking the patient to sit forward, to breathe in, to breathe out and hold, you're accentuating the murmur and making things easier on yourself. You're also demonstrating to the examiner that you know how to examine the heart. In aortic stenosis, the murmur radiates to the carotid areas, and it's important to auscultate for this. Can you breathe in, breathe out, and hold it? That's fine. And breathe normally. Having auscultated the chest, we're next going to sit the patient forward and examine the lungs, listening for any evidence of any pulmonary edema. Sit forward. Okay. There's no need to perform a full respiratory examination. Breathe in, breathe out, keep going. If there was evidence of pulmonary edema, you'd hear this as being fine end inspiratory crepitations. Relax back for me, Chris. It's important to examine for peripheral edema, and we're going to do that now. There's no evidence of any pedal edema in this case. We're now almost at the end of the cardiac examination, but it's important to tie everything together. For example, if you thought that the patient had evidence of congestive cardiac failure or had evidence of tricuspid regurgitation, and you wanted to take things a step further, if you have time, then examine for any pulsatile hepatomegaly. You'd be able to feel the pulsations in your fingertips, but also if the liver was enlarged as in CCF, you would also feel that the liver edge was displaced downwards. We're at the end of the examination. It's important that you draw things together and make your own conclusions. I would at this point turn to the examiner and say that I would like to examine the patient's blood pressure, dipstick the urine for any blood or protein that you might expect with either endocarditis or hypertension if you're suspecting, say, a coarct, and that you would also examine for sacral edema, examine for an abdominal aneurysm, and also examine the pulses in the lower legs. To examine for sacral edema, sit the patient forward, and you're pressing over the sacral area. That's the end of the cardiovascular examination. Next, you need to present your findings succinctly to the examiners. Good luck.